Hello, everyone. And first of all, I would like to wish you a happy new year from the entire team of Medicine Expert to all of you. How are you all? Am I audible to you? If I'm audible to you, write in the chat box so that we can start the webinar properly. So I guess my voice is clear. So yeah, thank you so much, Doctor. So yeah, let me first introduce our amazing mentors of our AMC chapter that are going to be your mentors in the courses and all the courses that we are offering you for the AMC preparation. We have the amazing faculty. We have Dr. Nabira, Dr. Amtul, Dr. Nilofer, Dr. Fahad, Dr. Sumaya, Dr. David, and Dr. Chinmay, and many more amazing experienced mentor who will be there for your guidance. And by Medicine Expert, we are offering you a lot of preparatory courses depending on your preparation so that we can give you the best plan for your exam preparation. Okay, so according to the plans, what we are offering is the first course that we are offering is the regular course, which is basically for those students who are starting their preparation from scratch and they haven't started yet and they want help in the basic knowledge. So for those students, we are offering the regular course, which is a theory-based course, and there will be 42 live sessions, and the recordings of the PDF will be added in this course. Apart from the live sessions, we're going to provide you the quizzes, the recall quizzes, notes and flashcards, the psychiatry workshop that will really help you to polish the skills of psychiatry. And this course duration will be for 4 months and it is starting from 20th of February. Then we have the Recall Crash course that is best for those people who want to practice the questions. Their basic knowledge is good, but they just want to practice the questions. For those students out there, we have the Recall Crash course. And in the Recall Crash course, we are offering live sessions, recording and PDF of live session for those students who will be unable to join the live sessions. And then apart from the live session, we are going to provide you everything that you need for your best preparation, like question bank, recalls, notes, like everything is added in this recall crash course. And the duration of this course will be for 3 months and it is starting from 10th of March. So to all the students out there who have joined us on this New Year celebration, we are offering 40% off and it is valid till 5th of January. So if you're planning to start your preparation for AMC, so what are you waiting for? You can just contact us and we can guide you about what plan would be best for you and how you can join that. So next, with our most favorite mentor, Dr. Nilofer Abru, we are offering exam week sessions that are starting from 10th of February. That is the first day of AMC exam week. And we conduct these sessions every month. When there is an AMC exam, we conduct these sessions and we do conduct the live session discussions in which we discuss that particular day exam questions, okay? So all the discussions are done by your favorite mentor, Dr. Nilofer Abru, and we discuss recalls on daily basis, and we get the best reviews from those live sessions because she's the best mentor out there who can guide you about the correct answers with the explanation. He or she is going to clear all your doubts that you will be having in your paper discussions. So again, we are offering 40% off on this course as well, so you can join that. So this was all for the courses that we are offering by Medicine Expert. So if you're interested in any course, you can reach out to us. We have shared our contact numbers in the chat box, and we can guide you about how you can join the course and how you can avail the discount, because the discount is valid for like 4 days only. And after 5th of January, the discount offer will be over, and so you have to avail the chance as soon as possible. So these are the amazing reviews from our beloved students who have joined us, trusted us, and joined our courses and have gone success. So now this was all from my side. Over to you, Dr. Nilofer. Can you please share your screen?
Thank you so much, Asma. Yes, I'm trying to share, but yeah, I'm sharing. Just 1 minute. Yeah, all good.
Yes, all good. We can see your screen now, and you can click on full screen so that we can see the full view of your presentation.
Just give me 1 second. Just 1 second.
Sure. Thank you.
Yes, doctor. So let's start our session. So in the start, I'm going to tell something like how we crack the exam, like how we go with this AMC MCQ exam, and like some tips and tricks. Because this is not as such easy exam, but yes, if you prepare wisely, definitely you will pass your exam in your first attempt. Like since 1 year, I am doing these recall sessions and all these things, so I will tell you everything from my own experience. So number like here, like written that make study partner always a study precisely, not the whole book of it. That we know that a study partner is very important because sometimes we study the things which are not important for the exam, and yes, at that point your study partner will help you. Second, always study precise, not the whole book of each subject. This is the thing that therefore, like we know that the John Motak JM is very important book for to pass the AMC exam. But yes, the whole book is not important. Some chapters, some topics are very important. So for that, yes, if you don't know like how, because I know that some students like who are like fresh graduate, they know that from which system or which topics are important from the which book we can go with like which book is important for which subject or like this. But like the doctors who have the gap, like for 3 years gap, 5 years gap, definitely they need some help. And for them, our courses are very important. Like our teachers, they will tell you that which topics are important and which chapters are important from the John Murtagh. So it for whole JM is not important. Less reading, more solving question. This is the one of the important point because uh, I heard this thing from my students that they said that in like we didn't remember anything. Like we read all the chapters, but nothing remember. Like we don't remember anything. Now what we can do? The main thing is that whenever you solve, whenever you read any topic, please solve the MCQs related to that topic at same time. Like if you are solving the GIT, if you are reading the GIT topic from the JM, it is good that read the GM topic from the RSCGP guidelines and then solve the recalls from related to the GIT. Solve the questions from the handbook related to the GIT. In this way, you will like cover whole the topic, but not the reading from the JM is not only sufficient. Definitely MCQs, or we can say the recalls, are very important. If you don't know that from where can I get the recalls, there definitely there are so many groups and everyone has the recalls. But yes, if you want to go with the proper answers, then you can join any courses which we offer, or you can join any courses. Second, Q banks. Q banks, like they are the med exam expert. They also offer the like Q banks. They have Q banks, and their Q banks is good. And second thing is that the Q banks are like affordable because there are so many like Amidex, Amplex. There are so many Q banks. But yes, we like from our country, like if we are in Pakistan, India, we don't we are unable to like afford that Qbank. They're very expensive. So yes, the med exam expert, they are very good, and they have good Qbank, and also they have good number of the recalls, and they have good number of the questions. Taking more mock exam, they have the mock exam as well. So it is good that before your exam, go with 2 or 3 mock exams, because I know some of the doctors like they have good knowledge, like they solve 2 or 3 years recalls, but at the time of the exam they are unable to finish their exam and they fail their exam. One of my student during November exam, like he was very good. I was like sure that he will pass his exam in November, and like he was with me like since 2 to 3 years he was doing these recalls, and since 2 to 3 since like he solved all 3 to 5 years recalls, and whenever I ask any question from him, he gave me the right explanation, right answer. Like he was very prepared. But unfortunately, he failed his November exam, and the reason was that he unable to complete his questions. Like only like I think 20 to 25 questions. He left 20 to 25 questions. So here I want to explain this thing as well. That yes, the doctors who left 5 questions, 10 questions, and also 20 questions, they pass their exam as well. I know some doctors. they unable to finish their exam on time, and they left 20 questions. One of my student, he left 20 questions, and he was like very scared for his exam, for his result, and he said that, Dr. Nilofer, I think I will fail. I said that no, maybe you will pass. And he was like, he passed his exam. And maybe because he passed exam because like he solved 120 or 130 questions, and maybe his 130 questions are like good marking question, therefore he passed. So yes, if you left if you're unable to finish your exam, still you have some chances. But yes, some of the doctors who not finished their exam, they failed as well. So it is good to practice mock exam before your real exam, because with the mock exams are they prepared just like the real exam. They have the 150 questions, and the length of the question, the number of the question, the like can say the pattern of the question, everything is just like the real exam question. So in this way, when you do the mock exam before the real exam, you will be prepared for the real exam. That because whenever we solve the recalls, whenever we solve the Q banks, we not we not consider the time. But yes, whenever you solve the mock exam, you just consider the time, that in 3 hours, or we can say the 2 hour, like the total hours is time duration is 255. So you must make in your mind that I must finish my exam in this 3 hours. So it is important. So mock exams are very important. Go before your exam, definitely go for 1 or 2 mock exams. Guidelines, yes, guidelines are the key, because the JM is still is very old. 8th edition, I don't know the 9th edition is there or not, but 8th edition is, because I hear that 9th edition is coming, but I don't know that it's came or not. But yes, 8th edition is there. Still in 8th edition, some of the guidelines are very old. But in the exam, the questions are new. So the questions came from the, just like the colon carcinoma. Or the exam, in the exam, the question this time, in the starting in February, March, the questions from the colon exam, they colon question, colon screening question, the questions came from the old guidelines. But in the end of the year, in 2024, in the end, like in September, October, November, the question comes from the new guidelines. The answers was from the new guidelines. So they give the questions in the exam, in the AMC exam, the questions comes from the new guidelines, not from the old. So GM is good for the sign and symptoms, because yes, we know that the symptoms and they don't change with the guidelines, but with the guidelines, the treatment change. So for the treatment, or for the screening purpose, or for the investigations, follow the guidelines. RCGP guidelines, RCH guidelines, these guidelines are important. So you just write on the Google, write your topic, write the RCGP guidelines, everything comes in front of you. So no, this is not as such difficult to search and it is not important to buy the red book or white book. No, they don't go with these books. Like I hear these things as well, that which book is important, red book or white book. No, just go with the Google. Just write your topic. For example, if you are covering the GIT, any topic from the GIT, let's like, for example, you are covering the colon cancer, colon carcinoma, then you just write the colon carcinoma screening, RCGP guidelines, the topic comes in front of you. No need to buy any book. No need to go with any like a book that this is the red book, white book. No. And just write latest guidelines. So everything comes new. The latest things comes in front of you. So with the investigations, for the treatment, yes, go with the guidelines, because they change. But for the signs, symptoms, because in the exam question, they will give you the symptoms, they will give you the signs, they will not give you the they will not give you the diagnosis. So yes, for the symptoms, for the signs, you can follow the GM. They will like in the exam, the symptom signs are completely like copy from the GM. And yes, for the pictures, you can follow the handbook, and for the pictures you can follow the GM. So, and yes, handbook, I know handbook is very old, but handbook is very, very important. They give you the questions as it is from the handbook. They give you the questions as it is from the explanation of the handbook. These points are very important, doctors. If you examine February, March, just follow these things. These very important to pass. These points are very important to pass the exam. AMC exam is not as such easy. It is very difficult exam. I saw the doctors who prepared very well, but they failed. The problem is that they don't follow these points. For the screening, go with the guidelines. For the treatment, go with the guidelines. For the investigations, go with the guidelines. For the symptoms, for the signs, for the pictures, go with the GM, with the handbook. The X-ray questions, still the X-ray questions comes from the this one handbook. The ECG questions comes from the handbook. They give the as it is ECG from the handbook. They give the as it is picture of the X-rays, as it is picture of the CT scan from the handbook. And yes, most important question, the picture of the lady with the thyroid swelling. Very important question, very important picture. They always give this picture. So these pictures are, the pictures of the handbook are very important for the exam, for the AMC exam. So these points are important. Don't like ignore the handbook. Don't say that handbook is very old. Yes, I know handbook is very old, but for the pictures, because definitely the sign and symptoms and these things never change. They are the same with the like in 2020 the symptoms same, in 2024 the symptoms same, and also in 1990 the symptoms same. So for the symptoms, for the signs, for the pictures, follow the for the like presentation, follow the handbook and JM. Okay, doctor, so let's go to the so how to pass the AMC exam? There's the specified course. Yes, definitely, I already told you that if you have gap, like for the fresh graduates as well, for the fresh graduates, recall crash course is very important. Like, because we every group, everywhere you will find these recalls. But yes, the right answers, I'm not saying that I will give you the 100%, I will tell you the 100% right. Definitely no one knows the 100% right answer, but yes, I will tell you the points related to the recall. I will tell you the points related to the options. Like, if these points come in your exam, go with that option. If these points come in your exam, go with that option. In this way, in the real exam, you will go with your own answers. I'm not saying you like that my answer is 100% right answer. Definitely my answer, like, I don't know what is the right answer, because in the exam, like, the only AMC knows the right answer. But yes, I will tell you that if this answer is right, why this answer is right, and if this option is right, then why this option is right, in this way. So for the fresh graduates, definitely their knowledge is good, so their knowledge are good, that they can go with the recall crash course. But yes, the doctors who have the like gap, like who have 2 years 3 years gap, and they don't do anything during this gap, so yes, for them the regular course is good. In the regular course, our teachers, they will tell you everything, like which topic is important, which book is important, and which recalls and everything important. So yes, we will tell you about the books. QBank, yes.
So for the question bank, we are offering like 5,000 plus questions that you can practice on the websites. Because what we see is a lot of students, what they do is, Dr. Nilofer, they just follow the PDFs they can get from the MEDEX like the previous years. With the help of that, they don't know the recent guidelines and they rely on those PDFs and they fail the exam in the end. So what I can suggest is try to get that question bank that is up to date according to the new guidelines on which you can practice the questions. Okay, so let's suppose if we are providing you the question bank, you can not only the see questions, you can attempt those questions, you can practice those questions, and after practicing those questions, you can get your score as well, so that you can assess your preparation where you are standing. Okay, and what are the areas on which you have to work more and on which questions you have to practice more. So we are providing topic wise question, quizzes, mock exams, everything that you need to practice and to get the desired score. So this was about the question bank. You can continue, Dr. Nilofer.
Yes, Asma, this is right. That mostly, doctor, they send me the message whenever I explain any question. They send me the message and they said that this question in the MEDEX, the answer is changed. The problem is that you are following the PDF files of the MEDEX, and these PDF files are made in 2019 and 2020. Every year, therefore, the mostly like doctors ask from me that Dr. Nilofer, Dr. Abro, this February exam, why this February exam is difficult. This February exam is not difficult. The questions are same. The problem is that in February, mostly guidelines change. They change the guidelines in January and December. That's why in February, the exam is a little bit difficult because we don't know that what they are following the, sorry, we don't know that they are following the new guidelines or the old guidelines. So therefore, in February, the number of the passing ratio is a little bit low. But the thing with therefore, like I'm just saying that the Q banks, like mostly they follow the AMEDEX 2019, 2020 files, and then they say that in the AMEDEX the answer is this. So the problem is that in the AMEDEX they follow the AMEDEX is very good. I follow during my time at my time I followed this AMEDEX. AMEDEX is good. I'm not saying that they are not good, but the problem is that you are following the old PDF files. So yes, go with the new QBank. With the in the Med Exam Expert, definitely you will find the new answers. You will find the answers with the authentic guidelines. And yes, so if you go with the new guidelines, definitely you will pass your exam. So QBank and recalls. Recalls are very important. I always say to my students that go with the at least 1 year recalls, and if you have time, go with the 3 years recalls. Recalls are very important. Whole 150 questions in the AMC exam, 150 questions comes from the recalls. But it is not like these 150 questions comes from 1 month recalls or 2 month recalls or 1 year recalls. No. The doctors who prepared well, the doctors who solved the 3 years recalls, and I saw some of the doctors, they like solve 5 years recalls. Their knowledge are very good, and they like pass their exam with very good numbers, like more than 350 or 370 marks. So this marking is very good. Like from the AMC, if you got like 370 marks or three, and I also found one doctor and he got like 392 marks. These were the very high score. I know scoring is not important in the AMC exam, but still, if you have a good knowledge, definitely you will get the good marking. So recalls are very important. 1 year recalls or the at least 1 year recalls. But if you have time, go with 3 years or 5 years recalls. Group discussion is very important. There are so many groups. The Med Exam Expert, they also have the group. So just join the groups and do the discussion. Because if you are solving one recall, definitely you will take more time to solve the recalls. But if you will solve the same recalls with your group, with your study partners, then you will take less time. They will share their knowledge and you will share your knowledge, and in this way you will solve one question within 5 minutes. But if you solve one recall without any study partner, without any group discussion, you try to solve the question, you will take 1 hour to solve only one question. So this is very important. Like from MBBS, we always like say this thing that from our time from MBBS, when this medical exam, this is we pass this medical exam with the group discussion. That your friend will tell you their knowledge, and you will share with your knowledge, and this way you will listen, and this way you will learn everything. So yes, group discussion is important. If you have any study group, go with that. If you have no any study group, then join the Med Exam Expert study groups as well. So let's see it in the other slide. Yeah, so it's how to pass AMC exam in first go. So start as early as possible. So commit to an examination date to give you something to plan for. Definitely, if you are planning that I will go for AMC exam in 2025, then first book your exam. When you book your exam, when you pay $3,000, then definitely you will start your preparation. Otherwise, you will not. If possible, study while undertaking clinical rotation or work. Make sure you choose your preparation resource wisely. This is important thing. Don't go with the unimportant things. You should use John Matak General Practice, the AMC Handbook, and question banks to prepare. Try to dedicate study time each day and take plenty of breaks. Work out the areas you are most weak and focus on them. Because when you will pass your exam, you will get one mark sheet from the AMC. And then in that mark sheet, they will not tell you the marking, but they will tell you that they are the percentage, like 100%, 75%, 50%, 25%. It is like this. So this is the grading. So if you are in the grade 1, you will come in the if your performance good, you will come in the grade A, and the grade B, and grade C. In this way, you will find that in which what we can say, in the which subjects or in which topic you are not like your preparation, you need more preparation. So they will give you the mark sheet, but not with the marking, but with this grading system. Try to do some practice where you emulate the actual condition of the AMC Part 1 MCQ exam, and work out if you have problems in areas such as time management. Time management is very important, doctors, because in November, like 5 to 6 doctors, they said that they are unable to finish their exam on time. They know all the questions. They in their exam was on the last day, and they got so many recalls. But the problem was that they didn't finish their exam on time, and they failed. So this is the problem. Time management is very important. Understanding the questions, and for to solving the question, first of always like to this is the trick. Like whenever you say the question, first see the options. If you see these options are related to the investigations of eosinophilic esophagitis, then definitely when you will read the question, you will make your diagnosis quickly. So before reading the question, first read your options, that what is in the options. What are the options? If in the option, they will give you the treatment for the achalasia. For example, if they give you the treatment, mostly they give the investigation of the achalasia. So if they give the investigation related to the GIT, like 24-hour pH monitoring and manometry, and if they give these options, then you will like prepare that this question is related to the GIT, and then you will read the question. And when you will read the question, you will see the sign and symptom related to the achalasia, then you make your diagnosis very quickly. So this is the very important trick. First read the question, first read the options, and then read the question. So let's start our group question discussion. I put some questions here from the 2024, and let's discuss these questions. Okay. So now question number 1 is the 39-year-old man I found to have unconscious and treated in ER, and he regained consciousness and shouted and said that he will give lessons to his wife and abusive to wife. His wife was applied away from him and against him for domestic violence, and they have 2 children. Most appropriate management. Inform police, admit under medical tribunal, and inform child protection services. So here, what is your first responsibility? Just 1 minute, doctors. Yeah. So it is here, like, what is your first responsibility? Here, your first responsibility is to save the life of wife. Inform child protection services is not important, because the children are with their mother. So definitely their life is also complete, but their life will come after mother. In this question, the patient said that he will give lessons to his wife and abusive to wife. So he's abusive to his wife. It means that his wife's life is in danger. So your first responsibility is to inform police. And then, yes, because of his condition is not good, like he has any psychiatric problem, he has any problem. So your second responsibility will be to admit this patient. Definitely, in this, like the question is, the patient is shouted and he said that he will give lessons. It means that he is in the aggressive, in this time he is aggressive, and he will not let you to admit him he will not give you the permission for admission. So definitely you will admit him under the medical tribunal. Medical tribunal, we know that there are the 3 doctors in Australian hospital. They are the 3 doctors. They are the team of the doctors, 3 doctors, and they are the medical tribunal, and they will tell you that this patient need treatment or not. So if this patient need treatment, that without his consent, we will admit this patient into the hospital. But this point comes after the informing police. What is your we are informing here, we are informing police because your first responsibility is to save the life of the wife. We will inform the police, and then we will consult with the medical tribunal, and when medical tribunal check his condition, and when then they will tell you that whether this patient needs admission or not. And if they say that yes, he needs treatment, then we will admit this patient without his consent. So admit under medical tribunal comes after informing police. There is no need to inform child protection services, because there is nothing like he has 2 children, but they are living with their mother, so their life is all good. They have no any problem. So informing child protection services in this question is not important. Prodromal schizophrenia. What lead to do diagnosis? History of taking drugs, thought insertion, low self-esteem, and ideas of references. So we know what is this prodromal. In the question, the recaller give you this diagnosis, the prodromal schizophrenia, and what lead to this diagnosis. But in the exam, they will give you the signs related to prodromal schizophrenia. They will give you the symptoms. Mostly they give in the exam, the most popular exam for the AMC related to prodromal is this, that the 18-year-old boy, he mostly spend his time into his room. He don't talk with his parents, he don't go outside, and sometimes his parents hear some voices or noises from his room. So then they give these options like history of taking drugs, thought insertion, low self-esteem, and ideas of preferences. So these, so in this, they will not tell you the they will give you the symptoms. They will give you the signs related to the prodromal schizophrenia, and then you will make your diagnosis that yes, this is the diagnosis. My diagnosis is this, and now what's what is the criteria? Now the criteria of prodromal phase of schizophrenia is little bit changed from the schizophrenia. We know about the schizophrenia. The criteria is that at least the symptoms, and the most important symptoms like hallucinations and all these things, and these symptoms must be present for the 6 months. This is for the schizophrenia, but for the prodromal phase, the criteria is little changed. Now let's see what is the criteria. Mark social isolation or withdrawal. In the exam question, they will tell you the 18-year-old boy, and he mostly spent his time in his room. He don't like to go to school. He don't like to go to his friends. He also don't like to talk with his parents. They will give you this question. Marked social isolation or withdrawal. Marked impairment in role functioning. Marked peculiar behavior. Marked impairment in personal hygiene and grooming. His room is not good, and you will find some bottles in his room. They will give you this bottle things, and then you realize that maybe in the options there is the drug history, so maybe this patient has the drug problem. So this drug, like the bottles in the room, because they mark impairment in personal hygiene and grooming, so this is just the distraction. This point that they found the bottles in his room, this is just the distraction. Go with the important thing that marked social isolation, and he is in his room. And second, blunted or inappropriate effect. Aggressive, he don't like to talk with his parents. Aggressive, like over deliberate or circumstantial speech, or poverty of the speech, or poverty of content of the speech. Odd beliefs or magical thinking. Unusual perceptual experiences. Mark lack of initiative, interest on energy. They also give you this point in the question as well. Marked lack of initiative, lack of interest in his life, lack of energy. This list of criteria has been dropped from the DSM because we always follow this DSM-4 for the schizophrenia. The whole picture of the prodromal phase should also be compared to the DSM-4 concepts of fully psychotic disorder that have not been present for long enough to meet the criteria for schizophrenia or schizoaffective disorder. The criteria number 1, the patient should have at least. So these are the criteria for the prodromal phase. The criteria for the schizophrenia is little change. The patient should have at least one of the following, one of the symptoms, positive symptoms, ideas of references. What are these symptoms? Ideas of references, odd beliefs, or magical thinking. The patient should have at least one of these symptoms. Ideas of references, odd beliefs, or magical thinking, perceptual disturbance, odd thinking and speech, paranoid ideation, odd behavior or appearance. So if you will find these, just 1 minute, doctors. Yeah, so if you will find these options in your question, go with these options. Category, because these points are important. These points are important in your for the diagnosis of the prodromal. These points like thought insertion, low self-esteem, and ideas of references. So in this one, I said that the positive symptoms, ideas of reference, odd beliefs or magical thinking, perceptual disturbance, odd thinking and speech, paranoid ideation, and odd behavior or appearance. The patient should have at least one of the following attenuated these symptoms. One of the following, at least the patient have these symptoms, then you can consider that this patient has the schizophrenia. All these, like in the question, they said that the prodromal schizophrenia was due to the diagnosis. All of these maybe comes in the must be present into the question, like history of the drug. Definitely, if the bottles in his room, then maybe he's taking drugs. Thought insertion, low esteem, ideas of preferences. But what is the criteria? According to the criteria, the ideas of preferences comes first. So magical thinking, positive symptoms, ideas of preferences, odd beliefs or magical thinking, perceptual disturbance. These symptoms, patients should have at least one of the following symptoms. Criteria number 2, consists of participants who have experienced transient psychotic symptoms which have spontaneously resolved within a week. Criteria number 3 is the combination of genetic risk. As we know, there is the genetic risk in the schizophrenia. So in the combination of genetic risk, that is being the first degree relative of an individual with a diagnosis of schizophrenia. With changes in functioning, the patients must have undergone a substantial decline in the previous year. The criteria in the first two categories have been largely derived from positive symptoms. So these are the positive symptoms. We see these positive. So if you find any positive symptom in your exam question, go with their symptoms. 1 minute. Okay, so now let's see another common symptoms of the prodrome schizophrenia, covering the 5 domains include chronic anxiety, frequent mood swings, insomnia, memory problems, difficulties with concentration and focus, social isolation and withdrawal, inability to perform job duties or fulfill personal responsibilities, strange, seemingly illogical behavior, decline in hygiene and self-care skills. So these are the symptoms. Doctors, these are the symptoms in the common symptoms in the prodromal. There is no hallucination. There is no hallucination. There is no but in the like for the schizophrenia, like we say that the hallucination is important, but here nothing, just the most important, social isolation. In the exam question, they will give you the social isolation or withdrawal. They will give you this point that the 18 years old boy, he always live in his he always like found in his room. He don't go outside, he don't go to his friends, he don't like to talk with his parents. So in that way we say that this is the prodromal schizophrenia. And decline in hygiene and self-care skills, lack of emotions, low energy, and lack of interest in previously enjoyable activities. Lack of interest in his life and low of energy. Odd speech pattern, unusual, clearly irrational belief bordering on crossing into the delusionals. Report of strange perception and possibly indicating the presence of mild hallucinations. But for the schizophrenia, yes, there must be the hallucination for the like diagnosis of schizophrenia. Hallucination what must be there, and not for only for 1 month or 2 months, but at least for 6 months. Then we can see that this is the schizophrenia. But for the prodromal schizophrenia, hallucination is not important symptom. The prodromal symptoms of schizophrenia will tend to escalate the both intensity and number over time. There is no clear and definitive time frame that indicate how long the schizophrenia prodrome will last before schizophrenia develops. So this is the important point, because I am focusing on these points because whenever I solve this question, whenever I say that this is the schizophrenia, doctor says that no doctor, there is no hallucination. No doctor, for the schizophrenia there must be the symptoms for 6 months. No. That criteria is for the schizophrenia. That criteria is not for the prodromal phase of the schizophrenia. And this question is related to the prodromal phase of the schizophrenia. So for the prodromal schizophrenia, there is no clear and definitive time frame. It is not like for the 6 months or 1 year. Maybe the symptoms like the patient has this prodromal symptoms like since 2 years or 3 years, and now he diagnosed with the schizophrenia. For the schizophrenia, yes, hallucination is important. For the schizophrenia, 6 months criteria is very important, but not for the prodromal phase. Second question, very important question. This is the SVT, stable patient, and SVT ECG asking most appropriate next step. This question, they always give this SVT ECG from the handbook. Handbook question, the ECGs, the picture of the ECGs from the handbook, they are very important, and also from the GM. In the GM, there are the 2 pages in the cardiac chapter, and all the ECGs are there. They are very important. Go with that ECGs. Before your exam, just quickly review all the ECGs which are in the GM and the handbook. Now, the stable patient. In the exam, definitely they will not tell you that this patient is stable or this patient is unstable. They will give you the signs. They will give you the temperature, what we can say, the blood pressure, pulse rate, and all these things. And then you can see that this patient is stable or not. So yes, if the patient is stable, we will go with the treatment. When the patient is unstable, we will go according to that. So here the recaller said that the patient is stable. So maybe the blood pressure is stable, the BP is stable, but the ECG is for the SVT. Now the most appropriate next step. Adenosine, amiodarone, maneuver, or the cardioversion. We know that if in the question, if the unstable, we go with the cardioversion. But if the patient is stable, then we will go with the steps. Initial, most appropriate, next step. They are asking most appropriate next step. So your next step always will be first step. Most appropriate, but this is next. So here again, the doctor is confused that this is the appropriate. I am agree with this word that this is the appropriate, but this is next. Next is always next. Keep this in your keep this point in your mind that next is always next. Next is not best or if they give you the word appropriate, it doesn't mean that they are asking about the best. No, they are asking about the next. So next appropriate, only next is always next. So your first step will be next means your first step. If the first step is already done, then definitely second step. In the exam question, they will tell you that vagal maneuver is already done. If this vagal maneuver is already done, then definitely your next step, next step will be second step. But if in the exam question nothing is mentioned, no treatment done, then your next step will be your first step, vagal maneuver. So this is the management of the PSVT from the GM. Now let's see what the GM says that vagal stimulation can be attempted carotid sinus massage in the first treatment of choice. Other methods of vagal stimulation include Valsalva maneuver, self-induced vomiting, ocular pressure, cold ice water to face or sunning ice, immersion of the face in water. If vagal stimulation fails, this is the first step. But if vagal stimulation is fail, then we can go with the adenosine. Then your next step will be adenosine. In the exam question, they will tell you that vagal stimulation is already done. Now, what is the next step? Then your next step will be adenosine. If vagal stimulation fails, give adenosine IV. Try 6 mg first over 5 to 10 seconds, then 12 mg in 2 minutes if unsuccessful, then 18 mg in 2 minutes if necessary and well tolerated. Second line treatment is verapamil. Verapamil 1 mg minute up to 10 to 15, provided patient is not taking a beta blocker. So you must see before verapamil, you must know that patient is taking beta blocker or not. Adenosine causes less hypotension than verapamil, but may cause bronchospasm in asthmatic. So if the patient is asthmatic, in the exam question, they will give you all these points. The exam question will be more clear. In the exam question, if they say that the patient is asthmatic, then definitely we will not, like adenosine, will not give him adenosine. Adenosine causes less hypotension than verapamil, but may cause bronchospasm. So therefore, we will not give adenosine in asthmatic patient. Use only if narrow QRS and BP and carefully monitor blood pressure. Avoid verapamil if taking beta blocker. If in the exam question the patient is taking beta blockers, then definitely we avoid verapamil in that patient. So this is from the GM. Now let's see. The ECG should be evaluated for the presence of abnormal rhythm. And just 1 minute. Yeah, pre-excitation and prolonged QT intervals and tachycardia, segment abnormalities or evidence of underlying heart disease. The presence of pre-excitation on the resting ECG is in a patient with history of proximal regular palpitation is sufficient for the perception and diagnosis of AVR. ECG findings. What are the ECG findings in the SVT? They will give you the ECG. Then definitely you will find. Sometimes they give you the scenario, but sometimes they give you the ECG only. So regular tachycardia. Normally, 140 to 180 QRS complex is usually narrow and P wave often not visible. So these are the important for the ECG of the SVT. Blood testing, now SVT treatment. Mostly they ask the treatment related question for the SVT. The treatment for the AVRT or AVNRT is the same for narrow complex tachycardia. Do not use these. Forward. Now modified Valsalva. Number first is carotid sinus massage. I'm not reading everything because we have only 1 hour, so I want to discuss more questions. So therefore, I'm just only pointing out the most important points. I'm not reading all the slides. Patient span with neck hyperextended, apply gentle massage for 50. This is the carotid sinus massage. Vagal maneuver should only be attempted in child who is clinically stable. So we know that for the stable patient, we will do the vagal maneuver. Otherwise, we will not do this vagal maneuver. What we will do the cardioversion if patient is not stable. Mainstay of treatment and chemical cardioversion using intravenous adenosine if vagal maneuver is already done. Sometimes in the question they mention that vagal maneuver is already done, or we can say the initial management is already done. Now what is your next step? Then your next step will be intravenous adenosine. This is recommended to be given at increment of 6 mg, 12 mg, and then further 12 mg dose. Adenosine has a very short half-life and should be given via large vein, ideally in the antecubital fossa, and given as a rapid bolus. Okay, so this is these doses are not important. Side effects are very short lasting, but patients should be warned of these: flushing, chest discomfort, shortness of breath, and head. Adenosis is contraindicated in patients with severe asthma. So this is the important point. So in the exam question, if they say that the patient is asthmatic, they don't go with the adenosine, they go with the verapamil. Adenosine is not contraindicated in patient with WPW where there's a narrow complex tachycardia. Verapamil for the avoid in patients on beta blocker. Now again the same point. Okay, so verapamil verapamil, if the patient is on the beta blocker, then we avoid verapamil. Pre-treatment with calcium, for example, 1 gram calcium gluconate over 2 to 3 minutes can reduce the hypotension effect without affecting the antiarrhythmic effects of verapamil. So DC cardioversion in unstable patients, DC cardioversion may be most appropriate management. So this is all about the treatment. So if in the exam question they ask what is your next step, if they said initial treatment already done, it means that the vagal maneuver is already done. Now what is your next step? Your next step will be adenosine. If they said that the patient is asthmatic, that we will not give the adenosine, we will give the verapamil. If they said the patient is already on the beta blocker, now what is your next step? Then your next step will be adenosine. We will not give the verapamil. And if they are saying that if in the exam question they give you the blood pressure and pulse rate and all these things, and you see that with the blood pressure and pulse rate, the patient is not stable, it means that the patient is unstable, then go with the DC cardioversion. So just remember all these points and mark that because this SPT question is very important. I think in August, September, October, November, like in all months, this question repeated in 2024. Okay, doctors, let's move to the next question. So this is the SPT discharge criteria, and this is the picture from the this RCGP guideline. So what is this? Oxygen via NC insert IV cardioversion and vagal if does not rely other steps may require immediate DC cardioversion if the patient is unstable. Like if the patient is in the shock, it means that the patient is unstable. If the patient is unstable, then immediate DC cardioversion. But if the patient is stable, it means no. Here it is written. Sorry. Yeah, it is written shock, yes or no. If yes, then immediate DC cardioversion. If no, then vagal maneuver. If vagal maneuver is not ongoing SVT, like still there is no any like improvement, then go with the adenosine. So this is the treatment with the adenosine, and then if with the after adenosine, the verapamil is there. So this picture is from the RSCGP guideline. Now let's see. This is all adenosine and consult cardio. If still the SVT is there and not is not like improved, then you can go with the consult cardioversion regarding alternative treatment. So this ECG now we can discussing the question related to the child because sometimes they give the question related to the 8 years old child. So this in the child, what are the treatment options? This ECG came an 8-year-old child and he was stable and speaking and telling his symptoms. So the patient is stable. So what we will do adopted from this like the what we can say the explanation has come from the Sydney Children's Hospital Network. But what they are saying that vagal maneuver are safe, minimally invasive. Vagal maneuver are safe, minimally invasive, and effective for reverting SVT in a hemodynamically stable child or infant. So it means that we can go with the vagal maneuver. Continuous cardiac monitoring should be applied prior to performing. If unsuccessful or child required, proceed to medical treatment as per the algorithm. Do not perform eyeball pressure or carotid sinus massage if they are no longer as they are no longer recommended. In the exam question, they give you the option of carotid sinus massage. So if they give you the option of carotid sinus massage, don't go with that option because they are no longer recommended. This is according to the SVT guidelines. You can check from the already mentioned in the previous slide. This is from the Sydney Children Australian guidelines, and it's clearly mentioned that For like carotid sinus massage, this is not this massage no longer recommended, so therefore we will not perform this like procedure into the child. Neonates and infants. In the exam question, they give you the question related to the 8 years, and sometimes they give you the question related to the neonates, infants less than 6 months. As if the diving reflects with facial immersion in ice water for 5 seconds. So if for the 6 months, less than 6 months, if the same question comes with less than 6 months and the patient is stable, now what is your next step? Your next step will be immersed in ice water for 5 seconds. So mark the answer according to the age of the patient. Facial immersion must not be used for infants in hemodynamic compromise or shock. Definitely for unstable patient, we will not do these procedures. These procedures are for the stable patient. Carefully explain to the parents what are you doing and why. The baby is attached to cardiac monitoring arm and are wrapped in a towel, and the whole face is immersed in an ice water slurry for 5 seconds. It is unnecessary to occlude the nostrils. This technique is safe and 90% effective in terminating SVT. Old infants, toddlers. Apply for the toddlers, like more than 6 months, but less than, like you can say the toddlers, like 2 or 3 years old child. Apply an ice cold face cloth or bag filled with ice slurry to the face for 15 to 30 seconds. So just see that this ice water is there for the infants, for the neonates, and for the older infants, but the duration is little change. For the neonates, less than 6 months, 5 seconds. So if in the exam question, they give you the age, and if they give you the options like facial immersion in ice water for 5 seconds or for 10 to 15 seconds. So for the if the age of the patient is less than 6 months, like if the age of the patient is 4 months, 3 months, then you can go with the facial immersion in ice water for 5 seconds. But if there is the age of the patient is 2 years or 3 years, then your answer will be immersion of the face into the for the 15 to in ice cold water for 15 to 30 seconds. So the duration is little change. While less effective than facial immersion, it is better tolerated in older infants. While techniques with the child in the span position, ask them to blow on their thumb or a 10 ml syringe after full inspiration for 10 to 15 seconds. Now, there should be no air escape and the child should be seen to strain. Modified Valsalva maneuver performed as above in the semi. So this is just a procedure how we can perform the procedure not come into the exam. So, okay. So now next step, definitely if the maneuver is failed, then your next step will be adenosine. Adenosine has a very short, that's a, already I explained you this thing, the short half-life of 5 to 10 seconds, that's by briefly blocking AV node conduction. Adenosine side effects, same transient flushing and chest sinus discomfort are relatively common side effects, and these typically correlate to a brief pause on the ECG stress as the AV node is being blocked. And rarely atrial fibrillation and prolonged pauses may occur, and exacerbation of the asthma due to bronchospasm. So avoid in patient with history of severe asthma or active wheeze at time of experiencing SVT. So at the time of if in the question, they will not directly tell you the asthma. They will say that the patient, the ECG of the SVT, and the patient comes in the SVT, but the patient has wheeze as well. Now, what is your next step? You will not give the adenosine. Why? Here it is clearly mentioned that avoid in patients with history of severe asthma or active wheeze. So in the exam question, they will tell you, maybe they will tell you that this is the SVT patient and they have the active wheeze as well. They will not mention the word asthma, but they will mention the word active wheeze. So don't go with the adenosine in these patients. Adenosine contraindicated patient taking diapyramidol require a low dose of adenosine for post-cardiac transplant patients and for adenosine. So this is the contraindication and other adenosine treatment considerations. And in the last, verapamil. Contraindicated in children less than 12 months. So if in the exam question they give you the less than 12 months verapamil, don't go with the verapamil due to irreversible hypotension and lethal vascular or ventricular dysfunction. Not routinely used in children despite increasing use of calcium channel blocker in adults for the management of SVT. Patient is smoking. Now let's go to the next question. Patient is smoking history 20 years. Just 1 minute, doctors. Just 1 minute. Okay, let's move to the next question. Patient smoking history 20 years. Hemoptysis, weight loss, night sweat, no fever, immigrant 10 years ago from Vietnam, chest crackles on both upper side. Tuberculosis, carcinoma of the lung, pneumonia, fibrosis. In the question, doctors, for this lung questions, or we can say the lung carcinoma, sometimes not sometimes, like we always like confused with the these options. Like mostly we confuse between two options or three options, and we because the questions are not like clearly explained. But yes, there are some tricks to solve these questions. If in the exam question they give you the point, like they give you the hint, patient smoking history 10 years, 20 years, blindly go with the carcinoma, this lung carcinoma, because this is the point in the RCGP guidelines. The point mentioned that if there is the smoking history, the most common condition with the smoking history, the most common condition is carcinoma of the lung. So if you are confused, like if you are unable to make your diagnosis, if you are confused between 2 points, sometimes the doctors confuse between carcinoma of lung and mesothelioma, sometimes doctors confuse between carcinoma of the lung and asbestosis, sometimes they confuse with the carcinoma of the lung and the TB. Here there's no fever, we can say that this is not the tuberculosis, but they said that no, maybe it is TB because there is the history of Vietnam and there is history of weight loss, and also there is the crackles on the both upper, so maybe this is the TB. But the point is there here, smoking history, if there is the smoking, I am agree with this point that smoking also one of the risk factor in the TB. I agree with this point that the patients who smoke, their lungs are weak and they have more chances of tuberculosis. I agree with this point. And here there's the Vietnam history, like the travel history, and also the weight loss, and also the hemoptysis. But still I will go with the carcinoma of the lung. Because this patient, if this patient comes to me, if this patient comes in front of me, first I will rule out the carcinoma of the lung, and then I will go with the other. If I like completely sure that this patient has no any carcinoma, then I will go with the TB and all these other things. So for these type of the questions, they are not asking for the definitive diagnosis. They are asking what is your diagnosis, like how you will start your diagnosis, how you will start your workout for this patient. So for this patient, your first diagnosis must be carcinoma of the lung, and this is according to the RCGP, that if there is the history of smoking history, if there is the smoking history, your first diagnosis always will be carcinoma of the lung. First rule out carcinoma of the lung. If the carcinoma of the lung is already ruled out, then your next step, your next diagnosis will be TB. So for this patient, carcinoma of the lung is the most appropriate answer, not no TB. This is the because I remember this question, and this question comes in the September and October, and I remember at that time doctor said that this is more towards TB. Why? Because of the travel history, and also the weight loss, and also the hepatitis, and also crackles on the both upper. I said that no. The first diagnosis will be carcinoma of the lung because of the smoking history, and then I will go with the TB. So if this patient comes to me, I will first rule out the carcinoma of the lung. In the patient coughing a bright red blood or blood clot, as in carcinoma of the lung, tuberculosis, pulmonary embolism, blood tricks, purulent sputum, as in bronchitis, bronchiectasis, or pneumonia, blood trick. So these are the sputum. Hemoptysis is a chronic smoker, is often due to bronchitis, but carcinoma of the lung, this is the important point. Hemoptysis in a chronic smoker is often due to bronchitis, maybe because of the, but carcinoma of the lung must always be ruled out. Your first diagnosis always will be carcinoma of the lung. First rule out carcinoma of the lung and then go with the other steps, with the other diagnosis, especially when the patient has associated symptoms such as weight loss. Chronic cough with fever and weight loss complicated by hemoptysis can be seen both in tuberculosis and bronchitis, although the latter often has more marked sputum production. Like your TB, like if your diagnosis is TB, this also right. Maybe if you mark the TB, maybe you will get some marks. But yes, if you mark the carcinoma of the lung, you will get more good marks. Because in this question, like, this is not a 100% right answer. You will not, like, your diagnosis not will be the 100%, because definitely when you will go with the investigations, when you will rule out the condition, then you will go with your 100% diagnosis. So in this question, there's only the symptoms. So with the symptoms, we will not sure with our diagnosis. But yes, the AMC wants to know that how you will like go with this patient, like how you will start the investigations for this patient. So your first diagnosis will be carcinoma of the lung because of the chronic smoker. It is clearly mentioned that, but carcinoma of the lung must always be ruled out, especially when the patient has associated symptoms such as weight loss. And then you can go with the other problems. STD, just 1 minute. Okay, so I will go with a few more questions because I think we already, it was the only 1 hour webinar, but yes, I'll go with some more questions as well. Let's see. STD, chlamydia diagnosis, chlamydia positive and with symptoms. So that the patient has the chlamydia, then the question, the caller said that there's the symptoms related to the chlamydia, and chlamydia like investigation is already done and it comes positive. Now, what is your next step? Azithromycin, like single, and cetrazone or the doxy for 7 days. Now let's see treatment consideration if the patient is pregnant. So now they could give you the question with the pregnant lady, and they will give you the question with the non-pregnant lady. So in the pregnancy, screening for chlamydia and other STI during routine antenatal screening is recommended to reduce the risk of pregnancy-related complications. For example, premature rupture of the membrane or transmission of the baby during vaginal delivery. So the STI management guidelines are a useful reference for the diagnosis management of chlamydia. The recommendation treatment in pregnant women. This is the important point for our question. The recommended treatment in pregnant women is an immediate dose of azithromycin 1 gram orally. This is for the pregnant lady. So if the question comes with the pregnant lady, so your next step will be, your immediate treatment will be immediate dose of azithromycin 1 gram orally. Although safe for use during early pregnancy, tetracycline causes discoloration of the baby's teeth, and a test of cure is recommended at 4 weeks of pregnant woman. So your immediate, what is your immediate dose? Your immediate dose will be azithromycin 1 gram orally. STI management guidelines now recommend patient with uncomplicated, if there is no symptoms. If there is no symptoms, but you just go for the screening and the chlamydia comes positive, now what is your treatment? Patients with uncomplicated urogenital infection be treated with treatment with doxycycline orally for 7 days. This is for those patients who are uncomplicated, like no symptoms, nothing. The patient comes to you for the screening, chlamydia positive. Now, what is the next step? Your next step will be orally for 7 days. Doxycycline, 7 days. So, patient with uncomplicated urogenital infection, there's the infection, uncomplicated. There's no complications, but there is infection. Be treated with doxycycline. 100 mg twice daily BD orally for 7 days. An immediate dose of azithromycin 1 gram orally. So if you find that option azithromycin immediate dose of azithromycin 1 gram orally, go with that option. Otherwise, go with the doxycycline orally for 7 days. Clinical trial evidence suggests doxycycline and azithromycin have comparable efficiency for treating urogenital infection in women. However, because azithromycin is increasingly implicated in antimicrobial resistance and other STIs, for example, gonorrhea and genitalium, there is now a shift globally towards the doxycycline as first line treatment. So that's my point in the exam question, because in our question azithromycin is also there and doxycycline is also there. So now what is the right answer? Your right answer will be doxycycline, and this is now confirmed from this point. They said that there is now a shift globally towards doxycycline as first line treatment. The recommended first-line treatment for anorectal chlamydia is doxycycline 100 mg BD orally for 7 days. If asymptomatic, 21 days if symptomatic. So this is the thing. If the patient is asymptomatic, like this patient comes to you for the screening and the chlamydia comes positive. Now what is your next step? Your next step will be doxycycline for 7 days. But the patient has symptoms. If the patient has symptoms, your next step will be doxycycline orally for 21 days. In our question, the symptoms. I think in our question, the symptoms are there. Yes, in our question, the symptoms are there. Like STD, Sexually transmitted disease, chlamydia treatment, chlamydia positive, and with symptoms. The patient comes with symptoms. But the problem is that in the options, the recaller missed the option of doxycycline for 21 days. If you find the option, this is the thing. Don't go with the recallers only. This is the point. Like recallers only remember those options, only remember the options which they remember, and second, which they marked. Recallers only remember those options which they mark and which they are confused between two. If they are confused between two like options, they only remember that two options. So don't go with the recallers only. Go with the topic. Now, for this question, just go with the chlamydia topic from the GM and also from the RSCGP and see what RSCGP says. So from the explanation, it is clearly mentioned that if the patient has no any symptoms, asymptomatic patient, then you can go with the doxycycline for 7 days. But if the patient has symptoms, then definitely you will go with the doxycycline for 21 days. Here there is no option of 21 days, therefore I mark 7 days. Single dose azithromycin, single dose. It is also mentioned that azithromycin single dose we give, but now it is not recommended. Azithromycin is not recommended. So now what is recommended? Doxycycline. So now your answer is 100% sure. Okay, doctor. So now this will be our last question, and I will finish this webinar. So this is the last question. Your ex-girlfriend wants to come to your practice for a checkup, and you are still interested in her. What to do? So this is the thing, conflict of interest. We know that in the ethics, like in the Australia, in the ethics, like this is the question in this type of the question. Whenever if you find any conflict of interest, this is the girlfriend. But one of the question, the question was like this, that not in the 2024, that question comes in 2021 or 22. That question was like this, that the patient go for the checkup to her GP with her mom. And then she said to her mom that the GP is father of my friend. The GP is father of my friend. Now, what is the next step? Then just send the patient to the another GP. Why? Because of the conflict of this. This is not only in the terms of this girlfriend ex-girlfriend relation or this. In the friendship also. You just send the patient to the other GP because of the conflict. This is the thing, and this is the important thing. So whenever if you find this type of the question, just send the patient to the other GP. So tell receptionist to tell her that another doctor will attend to her. Get a chaperone for the appointment. This is the chaperone. We don't do this for this type of the question. Attend to her by on your own. No, this is not right answer. According to the RACGP guidelines, the most appropriate course of action in this situation would be professional boundaries. The RACGP emphasizes maintaining clear professional boundaries between doctors and their patients. Given your personal history and ongoing feelings, it would be unethical to treat your ex-girlfriend as this could impair objectively and create a conflict of interest. Avoiding compromise care. In situations involving past or current personal relationship, care should be transferred to another healthcare provider to ensure the patient receives unbiased professional care and to protect both parties from any ethical concern. So it is good to send the patient to the other GP, and you will not refer. You just tell the receptionist to send the patient to the other GP. Consideration of other options. Why you are not going with the chaperone? While a chaperone can be helpful in such situations to protect both the patient and doctor, it does not address the core issue of potential bias or conflict of interest due to personal relationship. So in this personal relationship type of the question, we don't go with the chaperone. Attend to her on your own. Attending to her personally would be inappropriate due to the prior relationship and potential emotional involvement. This could compromise the personal boundary that must be maintained between a doctor and the patient. Recommended action. What is the recommended action? Ensure that ex-girlfriend is seen by another doctor in the practice to maintain professional boundaries and avoid any potential ethical issues. This approach aligns with the RCGP guidelines on maintaining professional standards and boundaries in doctor-patient relationship. So that was our last question. Thank you so much, doctors, for today's discussion. Thank you.